So I'm going to talk about some developments in this field of hormone therapy, and particularly the focus is on reducing the morbidity of therapy, and there's quite a bit of new data that you may not be familiar with. Next slide. So obviously this is a long-standing topic in our area. 1941 to 2018, 77 years of the hormone therapy era since Huggins and Hodges, but it remains a very active area, and the development of the new AR targeted agents means that the AR pathway is still a very, very robust area for new targeted agents. And in the last 10 years, a number of developments, much better understanding of the mechanisms of castration resistance, particularly treatment-induced survival mechanisms. Autocrine androgen synthesis, which is what abiraterone targets, AR mutations, splice variants, a switch as a result of castration that results in the cell producing a constitutively active variant of the androgen receptor that doesn't require ligand to activate the cell. Other alterations. Metabolic effects, 2007 was the Nancy Keating article that kind of opened up this whole field. We know a lot more about it now. Intermittent therapy, some large trials published in the last 5 or 6 years that I think have some important lessons for this, although it remains controversial. The importance of testosterone levels, this is a topic I've been quite involved in, and really we have, I think, quite convincing data now that this matters. The antagonists like degarelix and potential benefits over the agonists, and then we're in the era of abiraterone, enzalutamide, apalutamide, and so on, how to use these, and sequencing and vertical and horizontal integration, hot topics. So some recent observations about ADT. This is really a summary slide about what you can do to minimize adverse effects, and these are unwanted effects. They can have a very significant impact on quality of life. So obviously if you use less ADT therapy by using it intermittently, you can improve the quality of life during the off-treatment interval, and there's quite a lot of data to support this. Libido improves, amongst other things. You can use the usual therapies for erectile dysfunction. Hot flashes you can treat with a number of agents. I don't think intervention for hot flashes is as widespread as it probably should be. This is very bothersome for some patients. I like starting with evening primrose oil, which is a herbal compound, very appealing to patients. High levels of phytoestrogens that in most patients reduce the hot flashes. And choice number 2 is cyproterone acetate, which I still don't think is available in the US, but widely available in the rest of the world. Low dose of this drug, which is a progestational agent, just abolishes hot flashes. And other things are used as well. The gynecomastia you can treat with prophylactic radiation, other therapies. There's a whole aspect of management of diet and exercise that I think we need to do better on. By and large, those of us putting patients on ADT, and I realize I'm generalizing, and you may all be the exceptions, but we do not cajole the patient to monitor, to reduce their caloric intake, to try and reduce the degree of sarcopenia. Resistance training can prevent most of the muscle loss that occurs. Monitoring hemoglobin 1AC, because these patients are prone to insulin resistance, smoking cessation, the lipid story, memory exercises, bisphosphonates for the bone mineral density. So I'm going to go into some of these, probably not most of them, but where there's new developments. Now the first story I want to talk about is this, this adrenal pathway. These are the 3 well-recognized pathways of androgen synthesis. The normal one is the cholesterol pathway that goes to testosterone and DHT. In the castrate patient, you get dramatic upregulation of some of these key enzymes, AKR1C, SRD5A, which is the 5-alpha reductase, and that results in upregulation of pathways that it's called the backdoor pathway because it goes straight to DHT without going through testosterone. And this pathway is upregulated in prostate cancer cells in an effort to survive in the absence of androgen, like a cactus in the desert that makes its own water. But the other one I want to just point out is this adrenal pathway, and particularly it involves dihydroepiandrosterone. So testosterone diffuses into all cells passively. There is no cell surface receptor for testosterone. All cells have the same concentration of testosterone. The ones with 5-alpha reductase convert it to DHT, so it goes down, but it diffuses equally. DHEA is a polar molecule. It's got two hydroxyl groups on it, so it requires a transporter to get into cells. And this is where it gets interesting. The transporter is the same transporter, SLCO2B1, that is used by statins. And statins compete with this transporter to get into the cell. So in the castrate patient, DHEA serves as a precursor for intracellular testosterone. It's another route by which the cell can provide itself with testosterone and survive. And statins inhibit the uptake of DHEA. And so statins, aside from the blocking the melavenate pathway that probably has a role in stimulating prostate cancer, they probably have a role in just reducing the intracellular testosterone through this adrenal pathway. And here's a fairly recent study by Harshman, men on ADT, statins versus no statins, and actually a significant benefit in terms of time to CRPC, supporting this hypothesis that the statin is doing something useful in terms of further reducing intracellular testosterone levels. So, you know, statins have so many benefits in terms of cardiovascular health, and here's another one in men on ADT. So I think it's certainly something to consider. The other area is bone mineral density. Now, everyone knows about Xgeva and the other potent targeted agents. But I think there's also a role in the hormone-sensitive patient for just regular 1 pill a week alendronate or one of the other weak bisphosphonates. So this is a study we did a few years ago in men going on Lupron, alendronate versus placebo. And you know, everyone worries about loss of bone mineral density. 1 pill a week, there's the placebo, the predictable 2% loss of BMD. With just the alendronate, the bone mineral density increased 2%. Completely abrogates this tendency for bone mineral density loss. And whoops. And now there's a whole pile of randomized trials supporting this. And these are the placebo versus drug trials. The other ones are all one drug versus another, so you don't see so much of an effect. But you can see, compared to placebo, whether you use denosumab, alendronate, raloxifene, you get this clear benefit in bone mineral density. And I like alendronate because it's only 1 pill a week. If it's taken properly, it really has no side effects, and then you don't need to worry about the bone mineral density. Again, this is something that is not widely utilized at all, despite there being quite good randomized data on it. Metformin, we've heard about at this meeting, and I just want to show the 2 randomized studies. They're both small, that both show metformin at a dose of, in this study, 500 TID, in this study between 850 and 1700 milligrams per day. Again, as was mentioned a couple of days ago, really no side effects to this drug in the majority of patients. Higher fasting glucose, so basically it reduces glucose, it reduces waist circumference, it induces some weight loss. This is a significant difference down here is BMI is here, so BMI reduced. And you know, this may also have a role in an innocuous drug that reduces unwanted side effects of insulin resistance and weight gain in men on ADT. And then finally, exercise. If exercise were a drug, we would all take it because it has so many benefits, and there's a lot of evidence that exercise has a positive effect in prostate cancer progression, that it really has profound influence on epigenetic modulation, growth factor and cytokine release, insulin-like growth factor, which is a known mitogen for prostate cancer, tends to go along with insulin. High insulin levels is associated with high IGF levels, and it's reduced by exercise and so on. So again, this is, to me, a very key part. I guess the real message here is if you're putting patients on ADT, you need to become kind of the primary care physician, because a lot of the family doctors, I know there's a few family doctors here, a lot of family doctors are not too interested in this area and may not realize the opportunity for health intervention in these patients going on ADT. The next topic, a little more focused on the hormone therapy piece, is intermittent therapy. So I think now for the non-metastatic PSA failure patient, as a result of a number of large trials, it's widely accepted, and this is been accepted all over the world. For metastatic disease, it's still a controversy, and I'll come back to that. This is a summary of the largest trials of intermittent therapy. This PR7, Juanita Crook, the first author, L. Klotz, the last author on this large study, 1,500 patients approximately. The SWOG 9346, led by Maha Hussein, in metastatic disease. So I just want to emphasize one thing, which is the wide range of induction period from 3 months in the Portuguese trial. So they got 3 months of hormones, taken off, retreated when the PSA reached around 20, to 7 months in the SWOG trial. Some people have used 10 months or a year of induction therapy. And then the other point is that basically there is marked consistency of result. Non-inferior, non-inferior, no difference, etc. So with the exception of SWOG 9346, which is a controversial outcome, every study has shown intermittent therapy is non-inferior or no difference compared to continuous. This was our PR7 trial, absolute no difference between the two arms in terms of overall survival. This is the SWOG 9346, and the reason this was controversial is there was a non-significant trend to a benefit in the continuous arm, hazard ratio 1.09. The non-inferiority margin that's set when you plan the trial was 0.2 or 20%, so it didn't cross the non-inferiority margin, and there's the confidence limit. So the New England Journal article states, results inconclusive. The irony of this study is the authors themselves do not accept this conclusion. And if you read the article, you will see in the discussion section, they turn somersaults trying to explain that, well, while the results are inconclusive for non-inferiority, which is a double negative, it's hard to get your head around, we actually think intermittent therapy is not as good. But that's the conclusion in the paper. The reality is there's a way around this conundrum, which is to use PSA response. And this is from the same data set showing the incredible power of PSA response after 7 months in metastatic disease, a 6-fold difference in survival depending on whether the PSA goes to below 0.2 versus remains above 4. So I think what makes sense is you take the complete responders here who have a 7-year median survival, you offer them one trial of intermittent therapy. Some of these patients will have a very durable off-treatment interval and they benefit. The non-responders, there's no point using intermittent therapy, and I agree with the Maha Hussein and her cohort about that. So this is some new data we presented last year. It was just published about a month ago in the journal Urology. No one had ever really tested the period of induction. So although intermittent therapy is widely used, the duration of induction varies all over the map. And you might think that if you treat longer before you stop therapy, you'll get longer suppression of testosterone, maybe more apoptosis, and a longer time to PSA recovery and retreatment. And the somewhat counterintuitive observation in this study was that there was absolutely no difference. So this was approximately 90 patients randomized between 4 and 10 months of degarelix, so that's an important aspect, but basically no difference between 4 and 10 months in terms of the time to have PSA recovery and retreat. And this is the time to testosterone recovery. Also, again, perhaps surprisingly, no difference. So I think this is the only data on this question of what the optimal duration of induction therapy is. And I think the implication is if you're starting someone on intermittent therapy, you don't need to treat them for 8 months or a year. Give them 3 or 4 months of therapy if they have a complete PSA response, which many patients who are being treated for rising PSA do. You can stop after that period, and there's no apparent adverse effect in terms of the duration of the off-treatment interval. We're never going to know if the short duration of therapy has some subtle adverse outcome in terms of survival, because with 1,500 patients, the results in SWOG were inconclusive and showed absolutely no difference between 8 months and lifelong and the PR7. So to prove a difference between 4 and 10 months or 3 and 9 months of induction would require probably 10,000 patients. It won't happen. Now, the next topic is this issue of testosterone levels and whether it's important or not. And this is the original study that got this controversy going. It's now 11 years ago by Morbidity, retrospective, 72 patients, showed that the predictive effect of the testosterone on ADT was very powerful. So here is the patients who had a testosterone less than 20, which is kind of the modern standard, 20 to 50, and more than 50. And 50 nanograms is the historic definition of castration. But 50 was picked because until about 10 years ago, the standard assay for this, which is a chemoimmunoluminescence assay, really couldn't measure accurately below 50. So I was skeptical of this, partly as a proponent of intermittent therapy where the testosterone rises off treatment. How could whether the T was low or very low make such a difference? So I had the opportunity to actually test this with the PR7 patients because we had collected testosterone on them. We had 626 evaluable patients. This was prospective. These patients were very meticulously followed for more than 10 years. And so we gathered their testosterone, and basically I wanted to disprove Morbidity. And yet we actually completely vindicated his observation. So here you have, this is just one piece of data, time to CRPC as a function of the nadir testosterone, and whether we looked at nadir, at median testosterone, because it was measured every 3 months, maximum testosterone, time to CRPC, time to prostate cancer mortality. It was a very robust observation, and the hazard ratio somewhere around 1.5 to 2, depending on what threshold of testosterone. And this is cause-specific survival, same thing. And now there's a bunch of studies. These are the retrospective ones, and essentially they all show the same thing. Any study that has looked at testosterone, almost without exception, has found a benefit in terms of PFS or overall survival, PSA response. These are the prospective studies. And again, I just want to emphasize the consistency of this observation. Time to progression, cause-specific survival, and so on seems to do better if the testosterone is below somewhere around 20. Now, how can you explain this conundrum of intermittent therapy looking good, and yet the testosterone rises off treatment? And then all these studies that show that the low testosterone is better. And this is a solution to this conundrum, and the basic idea is when you treat, you need to treat hard and get the testosterone as low as possible, and perhaps ablate the AR pathway as definitively as possible. That's where the Spartan and Latitude and other studies that show the benefit of the AR targeted agents early. You need to hit hard, but it doesn't mean you have to hit hard forever. So you imagine this is a heterogeneous population of cells, and this is the 3 cell type model. The stem cells, which are androgen insensitive, the yellow cells, which are typical androgen sensitive cells that will die in response to any reasonable level of testosterone reduction, and the partially resistant, partially sensitive cells that require very low levels of testosterone before they respond. So do the thought experiment. You treat hard, T below 20, all you're left with is the stem cells. These 2 compartments disappear, and on repopulation, you get a more androgen sensitive phenotype. Whereas if you don't drop the testosterone below 20, you're left with the partially resistant cells that repopulate as well, so you get a more resistant phenotype. And of course, over time, you have upregulation of survival pathways and you get resistance, but later. So this simple model allows one to say, okay, low testosterone is important, and intermittent therapy can also be non-inferior to lifelong. The idea is hit hard during the treatment period, and then you can allow the testosterone recover, and you have repopulation with a more sensitive phenotype. And then the final point I want to talk about is the issue of agonists versus antagonists. And this is the issue of cardiovascular disease in men on ADT. There is a lot of data that cardiovascular disease is an issue, both in men with prostate cancer. Here is the cause of death in men with prostate cancer, and you can see that consistently cardiovascular death leads to more deaths in these patients than does the disease we're interested in. And these patients are considered by cardiology definitions to be high risk. So the definition of high risk is more than somewhere around 2 to 4% per year, and that fulfills the criteria for high risk according to various heart associations, more than 4% if they're on ADT. And I was involved in a couple of publications working with Ferring, who makes degarelix, that was a pooled analysis of 6 trials to try and get a handle on this. And overall, there was a benefit to degarelix. Now, if you look at the y-axis here, the numbers are relatively small, and it's only out to 1 year, and maybe this is real, maybe it's not. But when you tease out the patient with pre-existing cardiovascular disease, it starts to look much more convincing. So there's actually the hazard ratio for cardiovascular events is 0.5 with degarelix versus the agonist. And the event rate here is getting up to 15%. So this starts to look a little more real. Now, does this make sense? Both drugs lower testosterone. Testosterone induces metabolic syndrome, puts them at risk for insulin resistance, the obesity-related cardiovascular effects, etc. Why should there be a difference? So there's 2 explanations, and there's been recent data on both of these that I think really support their validity. One is the FSH story. The other is the effect of the LHRH agonists on inflammatory cells in endothelial plaques. So I'll just go into both of those briefly. This is from the key registration trial of degarelix, which I was the first author on, that showed that the LH drops dramatically in both, like 95%. But FSH, there's a difference. The FSH drops about 40% with the agonists and about 90% with the antagonists. And that has been reported now by a number of other groups, including this study. So does this matter? I mean, FSH is important in fertility, but certainly in the oncology field, we don't get too excited about it. But it turns out that FSH is involved in just about every single aspect of prostate cancer. It's involved in angiogenesis. So this is neovascularity in prostate cancer tumors. The endothelial cells are expressing FSH, and the hypothesis was FSH receptor signaling can be associated with tumor cell proliferation, upregulation of VEGF, and so on. FSH is involved in bone mass regulation. It is thought that the loss of bone mineral density in postmenopausal women is mainly mediated by FSH. It increases osteoclastogenesis, bone reabsorption. This GI2A coupled receptor activates osteoclasts, and so on. This is an amazing study just published in Nature that took these obesity-ogenic mice, these mice that develop obesity on a high-fat diet, and that also develop early cardiovascular disease. And an antibody to FSH completely stopped the development of atherosclerosis and obesity. And this here shows, for example, this is the green is the control antibody, the red is the FSH antibody, and difference in total fat mass is striking. FSH antibody stopped the obesity from occurring in these animals. So that's the FSH, and then you have the T cell activation story. So cardiovascular disease and inflammatory disease. These endothelial plaques have T helper cells, macrophages, and the amount of inflammation is directly related to the degree of plaque instability. And these inflammatory cells have GnRH receptors. So the hypothesis is that by stimulating, by agonistic effect of the LHRH agonists, you promote plaque destabilization. And this diagram shows both how FSH can activate the rank ligand pathway, and also LHRH agonists may stimulate T cell expansion, induce macrophage activation, and both these together induce plaque instability, which leads to plaque rupture and a thromboembolic event. Now this is the preclinical data that to me is really fascinating, and I was involved in some of this with Yoni Pinthas, who's a clinician scientist at McMaster. This is taking mice who are randomized between castration, LHRH agonists, and degarelix. The purple is the fat, and you can see there's a difference with degarelix versus the agonist in castration. This shows it graphically, degarelix versus enantone, which is luprolide. Really quite a striking difference in BMI, total body weight. There's a big difference in necrotic plaque area. This is a very powerful surrogate in these animals for the risk of cardiovascular disease and in humans. And then finally, this to me is the most elegant experiment. This is a cross breeding between an LDLR knockout mouse. So these mice develop very accelerated atherosclerosis, and an FSH receptor knockout mouse. So the combined mice are extremely prone to atherosclerosis and have a knockout of the FSH receptor, and the effect was profound protection against the atherosclerosis that otherwise developed in the mice. These FSH receptor knockout mice were non-obese and did not develop atherosclerosis. So this to me is a very elegant experiment that really supports the idea that the FSH may be mediating a lot of these effects, and it represents a very significant difference between degarelix and the agonists. And then here's one clinical study that, that's not what I had in mind. Can you just go back there? Oh. So the clinical trial I was just about to show just go to the second last slide. just in case anyone missed anything, you now have another chance to, review the data. Slow down. There. Okay. So this was 59 men with pre-existing cardiovascular disease, the group that's at risk. And the whole point about this plaque destabilization concept is it's only relevant in the patients who have the plaques. So it really is consistent with the observation that the difference in event rate, degarelix versus the agonists, is restricted to the patients who are at risk. Now, of course, we're all somewhat at risk. Every middle-aged person, with a few exceptions, has some plaques. But basically what he showed in this small randomized trial was that this was agonist versus antagonist, pre-existing disease. All the events occurred virtually in the agonist group, and the failure to have a fall in FSH was associated with a dramatically higher rate of cardiovascular events. If less than a 40% decrease in FSH, 2 times greater risk for cardiovascular events. So you have compelling preclinical data, compelling hypothesis, some clinical data supporting the observation, both from the pooled analysis and now from this small randomized trial. So final slide, the practical considerations: diet, exercise, smoking cessation, be the family doctor for the primary care physician, track their hemoglobin 1AC, track their lipids, consider a statin, low dose, consider an oral bisphosphonate, maybe metformin. Some people might argue this is polypharmacy, but these drugs are so widely used. They prevent the adverse effects in most cases. Consider intermittent therapy for the non-metastatic patient and for the patient who has metastatic disease who has an excellent biochemical response. You probably don't need more than 4 to 6 months in most patients if they have a complete biochemical response. Monitor testosterone. If they're not suppressed below 20, consider changing the drug. You've got at least half a dozen different drugs to use in this space. And if Lupron is not working, try Zoladex or Trelstar or one of the others. Consider degarelix if pre-existing cardiovascular disease. Obviously the drawback is monthly administration. Most patients prefer longer acting if they have the choice. So it's a trade-off, but I think the evidence is that this may be a safer drug for that subset of patients. Thank you very much.